This conference will now be recorded.
Hello, everybody. It's Johnny Antonucci. Along with my fellow moderators, Len and Rick. I think that's it. Well, Jim. I will be moderating the high-risk metastatic recurrent prostate cancer discussion group tonight for AnCan. We have some sponsors that we'd like to thank: Bayer, J&J, Myriad Genetics, Telix, Blue Earth, Novartis, Foundation Medicine. Rick, gone? Here?
Yes, no, Foundation Medicine is going to be here for the next year.
Excellent. Okay, thank you to all those for helping us put this show on without requiring us to push your products. So I'm going to go to John Graff first, just because we have a custom of making sure we get our new guys taken care of before we go on to the regular guys. And then we'll get to other people. John, you mind if I ask you a series of questions to get us oriented to what your current situation is?
Oh, please do.
Okay. How old are you?
I'm 61.
A young guy. Where do you live?
I live in Tampa, Florida. I'm sorry. I live in I don't even know where I live anymore. I live in Melbourne Beach, but I'm being treated in Tampa, Florida. So I'm about to go across the state to Tampa for about 6 weeks for radiation.
What's the name of your facility that you're going to?
Moffitt.
Okay. And who's your radiation oncologist?
Dan Fernandez.
When did you first get diagnosed, John?
Long time ago. It's been a long time. Last November, actually.
How did that come about?
I went to my primary care physician, and he did a PSA test, and PSA was very high, 19. He hadn't been tracking it, so that was kind of a problem, but it was 19. So he sent me to the urologist. They said, go straight to biopsy. They didn't do the MRI, did the biopsy, and 4 cores, 9, Lisa 9, 4 plus 5.
4 cores out of how many?
12.
Okay. And so you're 4 plus 5. You never had an MRI.
I did subsequently get an MRI.
Oh, when?
Much later, after shifting treatment to Moffitt, they ordered an MRI.
What did that reveal?
Not much. No seminal vesicle invasion, no extracapsular extension, no enlarged lymph nodes, PIRADS 4. So it looks like it's confined to the prostate. I also had a PSMA PET scan.
How did that come out?
It's complicated. I did it 2 months after starting Lupron or Eligard, and so it may have concealed. There may be occult or micrometastatic stuff that was concealed, but it showed one lymph node had equivocal uptake, SUV 1.2, just an external iliac lymph node.
1.2, pretty small.
Yeah, equivocal.
And everything else was entirely confined to the prostate?
Yeah, the prostate was glowing hot, like 10 something.
Yeah.
And, then the liver and the salivary glands were all, glowing, usual.
Okay. So any other diagnostic tests, genetic tests, or anything like that were done?
The local oncologist did the standard CT scan and the bone scan. That showed nothing. Started me on Eligard. Then he discouraged me from getting the PET scan because he said, "Oh, if they find metastases, we can't treat the primary." And so I delayed and delayed, and I finally decided to go to Moffitt and did the PET scan, and it showed just the one node. But that was after 2 months of ADT. Other scans, they did the MRI. They've done like setup for the. I've had HDR brachytherapy already, and I'm about to start the IMRT radiation, but no genetic testing. I'm about to talk to the genetic counselor, I guess tomorrow. That's one of the reasons I wanted to talk, see what kind of questions I should ask. They just do germline testing at Moffitt, and I can't think of any other external tests they did, any other tests they did or scans.
So you had the germline testing, but you don't know
No,
the
I have not.
results yet. Oh, you
I'm
haven't
gonna.
done it yet.
No, they're
Oh,
they're going to talk to me about it tomorrow.
pending. Okay. All right. When did you start your Elgard?
I think it was shortly after diagnosis. Like, let's see, I think in December I started it.
And how has it been agreeing with you?
Pretty horrible, They don't really warn you enough. They don't tell you what it's going to do. Um,
A lot of us
and it
had that
didn't.
same experience.
Yeah, it's worse than you can. They don't really tell you. They don't really give you a. They don't clue you in. Um, and my PSA after the biopsy went up to 27, and so on Eligard it went down from 27 to 11 after about 3 months. And when I went to Moffitt, they said, "Oh, we'll such an abiraterone," and on abiraterone it went from like the 11 down to 0.37 in like a month. So I'm on both the Eligard and abiraterone now.
They took you a lot more seriously at Moffitt, didn't they?
Yeah, they did. They had they had a whole bunch of people come in, and medical oncologist, radiation oncologist. Yeah, they took it a
Who's
lot more
your
seriously. Oncologists just want to do radiation and be done with it. Yeah.
Who's your medical oncologist?
He's a young guy, Akash Patel. He's a hematologist oncologist with interest in prostate cancer.
All right. So your current situation, uh, anti-testosterone treatment is beating the crap out of you, but your PSA has dropped drastically and is now 0.37. And
Correct.
you're waiting for further radiation therapy. And your 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 pathological indicators are all benign except for your Gleason score, which is what is prompting the extra medication you're on and the radiation treatment that you're getting.
Right. And the fact that PSA didn't come down on just Eligard, that's why they did the abiraterone. It only went down to 11.
Yeah. Okay.
And then there's
Excellent.
the lymph node too.
And there's questionable lymph node. So tell us a little more about how you're feeling physically with the ADT and the
Uh,
abiraterone.
I'm exhausted. I have like all the symptoms, the hot flashes, brain. I call it brain frog all the time instead of brain fog. Yeah, I have the brain fog. Um, Exhausted, discouraged, depressed. I hesitate to join these groups because everyone's so upbeat, and I don't feel like that at all. I'm scared and sad and depressed, and I know everyone says you got to exercise, but it's like the last thing I feel like doing. But I used to be fairly active, but I'm getting the muscle, and it goes fast. The muscle disappears fast. Um,
Yeah.
and I walk, but that's about it. I don't get much exercise, and it's just really beating me down.
How far do you get to walk before you have to?
Uh, I can about 2 miles, 3 miles along the beach, so it's a little harder than regular,
Yeah.
but yeah, it's tough. I don't know how you guys years you're on this stuff, and it's tough.
Yes, it is. What questions? So your questions for us have to do with what's coming.
Yeah,
What's it
what's
going to be
coming?
like being on abiraterone? What's it going to be like having radiation therapy, which sounds like it's going to be a large number of IMRT sessions, like
25, so 45
25?
per day. They did
Okay,
15 with the HDR.
okay.
And
And go ahead.
yeah, I have like comorbidities. I have type 2 diabetes and a little bit of high blood pressure. So it's like, dealing with the abiraterone is a little hard. They're going to have to finesse all my meds. And it's very difficult. And emotionally, physically, it's tough. And I had questions about, what's to come, um, if there's anything more I should be doing, what else I can do to better my odds, um, that kind of stuff.
What's your
Questions for
current
genetic.
uh, glycosylated hemoglobin A1C like now?
It's not bad. I was surprised the last blood test came in pretty good. Everything was okay. Some weird thing like ALT was down, and my uric acid was down, so that could be kidney impairment. I don't know. It was pretty good though. The blood work was pretty good.
What was it? The
It was like
diabetes?
5.5, I think.
5.5. Okay. And what's your current blood pressure like?
130 over 80.
Any swelling in your
Yeah,
legs,
like my
ankle?
feet are swelling a little bit.
Okay.
A little bit of neuropathy too, which I'm not sure where that's coming from. Could be the diabetes.
Is it new since you got put on treatment?
I had the tingling in the feet before, but now it's tingling in the feet, a little bit in the hands too. So it seems to have gotten worse.
Okay. What's important that I forgot to ask about?
I have a teenage son, and it's really tough. Makes me, I'm very sad. I feel like I'm giving him short shrift. Like I can't. Uh, I don't know how to explain it. I know they say statistics. 80% of the time you spend with your child is before they're 12, and so at least I feel like I take solace in the fact that he's gotten at least 80% of a dad because he just turned 13. But
Uh-huh.
it's tough. I'm separated from my wife. She's been pretty supportive though. But yeah, my support network is not great. I have family and friends, but they're scattered all around. They're not really in the immediate area, and it's kind of hard because I'm going to Tampa to get treatment because locally I live in Melbourne area, and there's not much good medical care here. So it's been tough.
Okay. Yeah, you're certainly bringing us back to our first years of treatment. But if you feel like seem like we're stable and in good moods, it kind of shows you that you will be feeling better too,
I
despite
hope so.
continuing your treatment. Um, I would like
Oh,
to just bring it up for discussion now. Anybody that wants to uh, talk to John, tell him about your own experience. Any?
I want to say one thing. It hardens me that I feel like I was all alone, like a Gleason 9, and it's the end. But it hardens me that there's so many people that are out there still living well, and it's heartening. Gives you hope.
Oh yeah,
Anyway,
everybody in here is probably 8, 9, 10. There may be some 3+4s. I don't really remember. Len, can I have you start things off?
Yeah, thanks, John. So, John, being that you have diabetes and high blood pressure, I think you're a good candidate to talk to your doctor about switching you from abiraterone to darolutamide because abiraterone contributes to high blood pressure, as our moderator John can tell you. I think he had that issue when he switched to darolutamide, and he felt a lot better. You'll probably feel a lot less fatigue. Most guys do. Um, so have that discussion with your doctor. Also, despite the fact that you feel fatigue, as we all did when we first started hormonal therapy, you have to push yourself to exercise because it's a bit paradoxical, but the less you do, the less you'll want to do or feel able to do, and the more rapid your muscle loss will occur. So that's pretty important. Don't treat yourself too gently with that. It's very important to get out there and get cardiovascular exercise as well as weightlifting. That's it for me, John.
Thanks. Yep.
Don, would
Yeah,
you
John.
chime in, please? Hi.
Yeah, I'm I live in Florida. I live down in Boca Raton, so I know where Melbourne is. I've been up there many times. As far as your depression, I mean, I'm a Gleason 9. I just completed 2 years of ADT last June, and the first couple of months are really hard. And I tell you, I was really depressed. I reached out through my oncologist and got a referral to a psychiatrist and a psychologist. And I'll tell you this, it helped me a tremendous amount. Uh, and I'm sure since you're over at Moffitt, they'll have someone that will work with you on the phone. You won't have to travel over there. And to this day, I still see my psychiatrist around every 6 weeks, and it's been very beneficial to me.
A great
I met
point.
with I met with a psychologist there. We didn't really click that well, so I have to keep looking. Yeah.
Yeah, get a different one. No problem. If Len's idea of switching to a different type of medication doesn't help your mood, then find a different psychologist and even consider antidepressants. It worked for me. I was a couple of months in and I was kind of still shaking with fear, and I got treated both with psychotherapy and medication, and it definitely helped me a lot as well.
Yeah, sleep's
So,
been a problem.
oh, it has?
Yeah.
Yeah, it
Especially
was.
at first. Better now, but
Yeah, you need
horrible at first.
something. You need something to help you sleep. Gary?
John, I just wanted to say that everything you have said is something that I went through with Gleason 5+4, and many of the other men, as John has said, on here have gone through it. The fear, the depression, the fatigue, like a couple of the men have just mentioned. I sought counseling, and I ended up with both counseling and medication, which helped me. So don't feel that you are an outlier by any means, because this is what it's like for most of us who have the numbers we do for this cancer.
Thank you. Dennis?
John, exactly what the others have been saying here. This beginning, this diagnosis is a tough time to get through. Uh, you find your feelings are very sensitive. I cried at the slightest little thing that would enter my mind. Tears would start running down. Uh, it's pretty normal with the drugs that you're on. I was almost the same thing, although I was de novo metastatic at diagnosis, so I had to go through chemo also. But that's 9 years ago. I'm still here. I play golf, go out, do lots of stuff. But what everybody's saying, the exercise is something you do have to push. And as you find you can change, you've got options with the drugs, and you might have to play around a little bit to find out what's really working the best for you. But further down the road, you get that PSA down to 0. Now discuss with your doc the option to take intermittent treatment or a break. You can do that. So, and that'll get you off some of the drugs that are giving you problems. That's what I got for you.
Great.
Thanks.
Well,
Alan,
Okay, so now I'm not going to repeat what everybody else has said, but a few quick things, John. If you have the time, first and third Thursday, men speaking freely, wonderful group. It's my favorite group. Smaller than this, but you get to talk about everything but treatment. So you may want to check that out at least once. The second piece, now I've forgotten one of them, but this one of the things I thought of. If you talk to your doctor about changing medicines, I didn't find it helpful to say, "Oh, I heard this at AnCan," and somebody, I forget who it was, maybe Len or John or somebody said, "Yeah, go find some research." So I'd ask Len to send you maybe just a research article, so that you could say, "Hey, listen, I read this, and this is where I got it from." Not that you heard it from AnCan. And I remember the third thing too. I was a psychologist, and I would tell clients, yeah, all I want are 4 visits. If you are not clicking and making progress and say, yeah, this is for me, I want you to find somebody else, because, treatment therapy is really a relationship, and sometimes you form it and sometimes you don't. So don't be afraid to go find somebody else to talk to. There you go.
Rick, I imagine you're busting with ideas.
I mean, I think people have really covered this well, and I just want to say to John, I'm really pleased you came in tonight, John. The first time's always kind of the hardest, and hopefully we're making you feel good enough that you want to come back. I just signed you up for the reminder for the Men Speaking Freely, so you'll get a little note before that meeting happens. I think Dr. John is leading the moderation in the next Men Speaking Freely, which will be on the 1st of May. Here's what I wanted to say to you, hearing a little more than we spoke about yesterday. I'm concerned about this guy Patel, because, as you say, he's not really a GU medical oncologist. The quality of GU med oncs at Moffitt is not great. They have a couple, but they're not terrific. And the fact that he put you on abiraterone, despite the fact that he was aware that you had blood pressure and diabetes issues, makes me think that he's not really thinking about your case. He's kind of working automatically. Now, I don't know how easy it is to switch. I can look at the names. I think there might be one person that we sort of like, but by and large, the GU medoncs there are not great. And in the long run, you might, after you've finished your radiation therapy, you might be better off thinking about switching to a quality GU medical oncologist. We are aware of a couple in the area. Well, on your side of the coast, we're aware of a couple, and we're aware of a very good one on the other side, but that doesn't really help you. I know that, but that's really what I wanted to say. I am really concerned that he didn't discuss an androgen blocker with you as opposed to abiraterone.
In his defense, he's kind of following my blood work very carefully. He's going to do every month, going to do blood draws. So every month he's going to check the blood work to make sure it's
It's a
standard
tough,
care, I guess.
yeah, it's a real tough one because you're better off to start with abiraterone if you can. At the same time, if you're not feeling great on it, and you have some comorbidities, it becomes more of a judgment call as to, is it worth you putting you in for that one first rather than the other one, and not putting you straight onto one of the what I call them the eyed brothers, enzalutamide, apalutamide, or darolutamide. We'd like to see you on darolutamide. But I think it is a discussion you can have with him. What do you think about moving to one of the receptor blockers, which is likely to have a lower impact on my diabetes and my blood pressure? It's a very genuine and considered request. And I just don't know if this guy knows well enough. I don't know how much he does. It's the sort of thing that we see from docs who are medical oncologists, but not genitourinary medical oncologists. And I know you're familiar with the terminology because you've listened to some of these groups before. Jack, you have your hand up.
Wait, Rick. I'm going to do something a little unusual because
Okay.
Graham has something to bring up and he has to leave in 5 minutes. So I'm going to break off the discussion with John and hold Jack for just a few minutes. Go to Graham, and then
I appreciate everyone's input. Thank you guys very much.
Oh, you're welcome. Graham, you didn't go yet, did you?
Okay, so I'll just review a little bit here. I had my prostate out in December the 4th. The pathology of that was a 4 + 5 = 9, a T3B. My PSA on January 31st was 9, and February 28th it was about 10.5. I started, I did a PET scan as well before I started the radiation and Orgovyx. I started the Orgovyx March 25th. The doctor had suggested now that I start abiraterone after the radiation. Now, I did have a blood test done, and that was April 17th. My PSA was 1.21.
Oh.
The testosterone total, I don't know if this is in that kind of figures that you guys use. A normal range of an NMOL over L is 6.7 to 25.7, and mine came up at 0.5.
Okay.
Now, you folks were suggesting that maybe I should be taking 3 drugs, including docetaxel. I brought this up with the doctor. He's still only 2 drugs. He did, give me a referral to a medical oncologist. So my doctor's the radiation oncologist. And you guys asked how many grays of total I was going to get, and it's 55. And it's throughout the pelvis using a VMAT radiation. I did get my PET scan results. I can go over that quickly because it means very little to me. It says there is a lesion with intense PSMA uptake anterior of the bladder, 19 by 10 millimeters. And then it says SUV max 8.3. PSMA avid lesion is demonstrated in the area of the right seminal vesicle. Max 8.2, 10 millimeters. A few millimeters ill-defined, moderately PSMA avid foci are seen in the right obturator area, SUV max 4.1. And then it says SUV max 3. And in the right peribladder space, SUV max 2.8, 7 millimeter. And in the left obturator area, SUV max 3.5. A PSMA avid node is demonstrated in the left external iliac area, SUV max 12.1, 6 by 4 millimeters. 2 PSMA avid nodes are demonstrated in the right common iliac area, 8 by 9 millimeter, max 14.5, 9 by 7 millimeter, SVV max 8.9. And then it just basically says there's no other PSMA positive areas, liver,
Okay.
that kind of thing.
Good. Okay, we got the picture. And you're pending. You're going to start radiation therapy soon, and they're going to.
I'm on the radiation therapy, and I've been doing that I had 8 radiation treatments.
Okay, very good. And they're going. I'm sure they're going across the whole pelvis with those kind of findings.
There's a total of 20.
Yeah.
And I've been 25 days on Orgovix in the pill form. He wanted me to do the pill form because he said it works faster.
Yes. Yeah, I'm sure you got that nice low PSA level as a result of that Orgovix. Okay. So we're caught up. What's next? What's on your mind for today?
So you guys hearing what I just read, any thoughts on, I know you don't give medical opinions, but thoughts on like whether I need to do Doxetel?
Well, let me explain. I just want to explain a couple of things. The reason why your RO, radiation oncologist, is sort of ducking the issue is because it's actually called docetaxel, and
Okay.
Or what's the commercial name? Taxol, isn't it? Taxol, the commercial name, but we say Dosi or docetaxel. Anyway, he cannot prescribe that, so it has to be prescribed by somebody else. So it's not so much he's saying no, I wouldn't do it. He's saying this is in another area. Now, the one thing I think we can say to you, and we can definitely ask the group what they think, because there have been other people who are de novo metastatic who have been in this situation, is that when you have the amount of uptake on your PSMA scan that you show, the standard of care, Taxotere, thank you, Len. Sorry, Taxotere, I should have remembered that. The standard of care is to do the Taxotere. In your case, particularly where you've got a lot of action around that bladder neck and you're relatively young, if it were me, I probably would want to do it. I'd opt to do it. It's not easy. You don't slide in. You get dropped in with a bang. But the bladder neck stuff concerns me more than what we see on the ribs or other spots elsewhere, because when it's around the bladder neck, it's in a position where it's easy to sort of move around and get out. So that's my 2 cents, and I would be meeting with him, and I would be inclined to consider it, given that you seem to have several spots. The rest of the treatment seems appropriate.
Okay.
Anybody else? What does anyone else here have anything to add for Graham?
This business that Rick is not really thoroughly worked out yet. And so the research oncologists have somewhat arbitrarily, not entirely, but somewhat arbitrarily set it as if you got 5 lesions outside the prostate or more, then it's worth going on with the docetaxel. And if you have less, it is not. different risk factors in our view different ways. So we'll be eager to hear it when you do get to that medical oncologist, what their opinion is about it. And you're okay that it wasn't started right away at the very beginning. That's perfectly fine. Your PSA is under control right now. Pretty good control. Anything else for Graham?
Well, yeah, Graham, I mean, what's your feeling about, how do you feel about adding the docetaxel? By the way, and you'll hear this referenced, that it's called triplet therapy. What you're on right now is called doublet therapy, and what we're saying is you should explore triplet therapy.
Yeah, right now on the Orgovix, I'm doing fine. I'm 25. No, I'm about 28 days maybe on that, and I feel good. Yeah, of course, one's reluctant to go on a third, much tougher drug, but
Sure.
you got to do what you got to do. Now, Dr. John was breaking up for me. I don't know if someone can kind of give me a quick what he said.
He broke up for all of us.
Oh,
Oh, I did.
I think what you were trying to say, Dr. John, is that maybe Graham wouldn't be considered a high volume because he doesn't have any distant metastases, and that may be why it
I
may
have
not.
one distant. I got one distant, and that was in the rib.
Oh, okay. I didn't hear that.
Yeah. Yeah, and did you say that you are on Orgovix plus abiraterone right now, Graham?
I'm on Orgovix.
Oh, so they haven't even added a second line. Is that right?
He's talking about adding that as soon as I finish the radiation.
Yeah. Again, I think what we said to you last week is we didn't understand why he'd be waiting on that.
Yeah.
So you need, and you don't need, but it would be suggested by the guidelines that you should be on either doublet or triplet right now. So no messing around with the abiraterone, and maybe add chemo. And if you were to add chemo, they usually would do it a reasonable time after you finish the radiation.
Okay.
Dennis, is your hand up for Graham?
Yes. A couple of quick things. Graham, just on this prostate cancer journey, you're going to find you're constantly trying to balance quality of life against overall survival time. And it's a thing that you throughout your whole journey, you'll have to make these decisions. But generally getting that docetaxel from which is what I also did with a number of meds that I had, gives you that big hit at first. You give up a little bit of your lifestyle quality of life, but you do it and then you're past that point. And generally, the reason I think it was best practice for people like yourself is they find it gives you longevity.
I've got some good questions now for the oncologist.
Okay. Fill us in afterwards next week, okay? We're eager to see you get on the best possible treatment.
Wait, there is no next week, Dr. John.
Are we at the end of the month? Okay.
Yes, the next meeting after this will be the 5th of May.
Okay. Graham, if you could come back on the 5th of May and catch us up.
Okay. Thank you.
I wouldn't be surprised if you're on at least abiraterone by then, but maybe that will even wait until after your RT. But we're all feeling a little bit anxious to get you on the second drug.
Yeah, and Graham, advocate for yourself, and push, for a little more. I mean, if it were me, I'd push for a little more than a little less. But
Yeah.
don't stand in awe of the doctors, because we
Yeah.
know
Well,
what the guidelines say.
yeah. The radiation oncologist got pretty defensive when I started to, in Canada, I guess you don't really get second opinions normally. And yeah, he got uncomfortable pretty quick.
Yeah, I'm sure it is. And the reason is because he knows you could be on more, and this is how he always does it. And he's not used to people saying to him, hello, are you sure you're doing the right thing? But the fact is that you can quote the guidelines and refer him to the guidelines.
And the guidelines, can I find those guidelines somewhere, or are they?
Yeah, the NCCN guidelines. There is a patient version. I'm pretty sure Canada follows the NCCN guidelines. I will email you. I'll email you the patient version, and I'll put a link to the doctor's version in the chat. But they are a little hard to follow until you understand how they work. The patient version is easier to follow, though.
Okay. Thank you.
Okay, so now, because we all have splendid memories, let's switch back to John Graff, finish up that discussion, and Jack had something to say.
Rick already said it. I was basically going to say pretty much what Rick said about the darolutamide argument versus the, he's type 2 diabetic, and he's got a good argument for darolutamide. So, I mean, I think if you had a medical oncologist who was willing to work with him and insurance, you'd be able to get the darolutamide with the, or, instead of the abiraterone, because of the prednisone situation, which is not too good for anybody with type 2 diabetes. That's all I was going to add.
John, are you still left with any questions for us?
I'm here. I appreciate. I just wanted to say that, like, the local oncologists weren't even considering abiraterone. They were just going to do Lupron, and it really is important to get to a center of excellence, as they say.
Yes, I think that's one thing that Rick has always tried to make sure that every one of us in AnCan is seeing really excellent GU medical oncologists.
Yeah, I mean, you heard what I said to you, John, before, and I have concerns. I think most of us in this group have a few concerns. I mean, it's not bad, it's not wrong. It's just not sure it's the best. And we're saying the same thing to Graham. Make sure that you try and get to the people who really know your condition, and they don't treat you like an like a robot, like an automat.
Oh, what else what I was remembering when John was talking? A year or two ago, we had something about talking to your children about cancer. You guys remember that? Is there anything that we have in the archives that we could direct him to? Because I think we recorded it.
Yeah, let me look.
Okay.
That would be appreciated, yes.
Yeah, we do have something. If not, I'll talk to our Alexa. She'll know. I'll talk to Alexa Jet and I'll ask her. I'm making a note, John, right now. You did ask us originally anything that you need to talk to about with the genetic counselor. Not really. I mean, we really need to see the results, and those results may be important. Do you? I know you said to me that you are Ashkenazi Jewish. Do you have any cancer in the family?
Yeah, a lot.
Tell us.
Basically, my mother's side of the family, almost everyone, all my aunts and uncles died from cancer. My grandparents on her side died from cancer. My mom died from cancer. My dad died from cancer. A lot of my cousins have cancer, so it's bad.
Which cancers?
Different cancers, but breast cancer and a lot of times for the women, breast cancer and prostate cancer.
Yep. Any
Road cancer.
pancreas in there?
One pancreas. I think so. Yeah, one pancreas. Yeah.
So, you may carry a inherited mutation. Frankly, if you do, there are some good options. But since you're well into the radiation at this point in time, we can't really switch you. But there are still options. There's a trial going on, but I'm not sure if it might be too late now that you've started, but there is a trial going on, but I don't want to get ahead of us. So just come back to us as soon as you know.
I know what's going on.
There isn't too much to ask specifically, but it's important that you share all of that history. John or Len, would you, anything else for the genetic counselor?
No, I agree that the kind of genes we're talking about are the kinds that are handed down from parent to child and run through families. With a history like that, you may have something that's making you vulnerable to cancer, and it may, who knows, it may even lead to some specific treatment. And the genetics counselor will be excellent at that when they talk to you.
All right, thanks.
Right, Len? Anything else?
Well, I'm just going to say, you guys seem to be tiptoeing around this, but I mean, what he just told us, screaming BRCA2, but
yes, it is.
But he may not have it, but that's what it's screaming. So who knows? He should definitely get tested.
Okay.
Thanks again.
Very good, John. We'll see you again in the future. Hopefully.
Hey, John.
Who's that?
Look, this is Jeff. Look at I'm 49% Ashkenazi, and my aunts, both my aunts got breast cancer. One of them died of it. My cousin died of it. My grandfather died of pancreatic. It's BRCA2. I mean, the Ashkenazi Jews have BRCA2, and almost definitely in his case, it's going to be BRCA2.
No. We can't say almost definitely. We can't say that.
How old did he get? How old was he when he got prostate cancer?
But we can't say it. What we can say is you are a candidate for BRCA2. You could also be a candidate for a Lynch mutation, or you might have nothing. We really don't know. What you are a candidate for is to get the test, and that's what you're doing. So that's all the right things. I would rather say, let's wait to see what happens when you get the results back, and then we'll give you great guidance. But John, don't be surprised if you carry a mutation. I'm sure you wouldn't be already. You've done your homework, and you know it's in the family.
Yep. Right for my kid now.
Yeah. Well, he may be testable. We'll find out after we get you tested. Let's go to Jim Marshall.
Yes, I would like to comment on John's stuff he put in the reminder that do not forget about the heart, because all of us are all concerned about the prostate, and every little thing we say is surely and with the prostate when it might be the heart, as I found out the hard way. So I just wanted to raise awareness, and I thank you, John, for that reminder, in the article.
Oh, you're welcome. Yeah, for everybody, Jim's 80th birthday present was a bypass surgery for his heart.
A three-bagger.
A three-bagger. Okay, thank you.
Did anybody else have any questions about John's heart piece in the reminder? Because if so, now would be the time to bring them up. It was a great piece, John, and thank you, and let it be on everybody's radar now that most centers of excellence do have a cardio-oncologist or an
A cardio,
onco-cardiologist.
cardio.
Yeah, which way round should it be, doctors on the
I
field?
know the first ones that came out called themselves cardio-oncologists, and the journal is the Journal of Cardio-Oncology, but I bet there's some people out there that start from oncology and specialize in the heart and call themselves oncocardiologists. I don't know. And if anybody has any questions about your heart, abnormal blood tests, cholesterol levels, stuff like that, just send me an email and I'll try to answer you. Richard, Virginia. You got to unmute. There you are.
The mic.
What's on your mind today?
A question about neuropathy and finding someone that is good at neuropathy, because I've got type 2 diabetes, and with the chemo, that just kind of added on, and it's been kind of building up the effects. And the local neurologist I have, I'll just say, isn't cutting it. I sometimes know more about what we're doing than he does. I know there's a center for peripheral neuropathy for diabetics, and I guess associated with it is peripheral neuropathy for associated with Kim. And I'm up at Johns Hopkins, and I'm trying to get into that, but they keep on wanting an EMG down here, and I'm with a neurologist I had. Well, you don't need that, was his answer for months. So, okay, what is the right answer, I guess, or any suggestions?
I think I'm a real believer in specialists and subspecialists personally. I'm just always amazed that somebody with a very specialized focus, how much they know. So if you think you might have access to a neurologist that specializes in peripheral neuropathy, especially diabetes, which you have, I would seek them out. If they won't see you without an EMG, you can either go to another local neurologist or I forget. Do you go to the VA?
No.
No. Rehab medicine doctors can also do nerve conduction studies. So a rehab medicine doctor or a neurologist, I don't know why, I don't know why they won't start your workup from scratch. They must think of themselves as like a tertiary referral center that only gets to people after they've been through 10 other neurologists, and they expect the whole workup to be handed to them right from scratch. So I'm sorry that they won't start from scratch with your workup and treatment. You sure about that, huh? They won't see you until you got one?
Yeah, that's what they told. Well, that's what Johns Hopkins has told me.
Yeah.
So the write-up they have, and they even have a treatment called Scrambler, which is another electromagnetic type of treatment that most people haven't heard about down here. So anyway. Oh, by the way, there are some that are a few that are supposed to be good, very highly regarded around here, and only problem is we're now talking September, October appointments from here.
It's so there's a lot of time. First of all, those distant appointments with subspecialists are frustrating, and a lot of people just hang up. But the date does get there, and neuropathy is not a rapidly progressing disease, so make the appointment because September will get here. You can always cancel it if you find somebody perfectly good in the meantime. And so I don't know. My personal feeling is that go ahead and do what you have to do to get to them. Now, Rick just brought up a good point in the chat. Maybe your oncology hospital or facility has a palliative care doc, and they're interested in all the ways in which having cancer makes your lives miserable and try to improve your quality of life. They probably have access to a neurologist or nerve conduction studies. Do you have access to a palliative care department?
Yeah, I have. Nova has a palliative care program that just started, 2 years ago.
I think it's a great suggestion. Palliative care draws from many different specialties, neurology and psychiatry and internal medicine and all kinds of different specialties. Maybe that would be a great way to get to somebody.
Okay.
Now there must be other guys in here with peripheral neuropathy, right? I'm sure I've heard some of you guys talk about your neuropathy. Jim, Rick, I know has some. Go ahead, Jim.
Yes, I wear compression socks, and it helps throughout the day. But then at night, anyway, I have to take them off. But it helps during the day. Thank you, VA. $35 a pair.
First, get a diagnosis because your neuropathy may be related to circulation and it may not. But yeah, good suggestion. Let's see. Somebody else has their hand up, but I don't know who. Oh, David up.
Yes, I've been dealing with neuropathy in my toes since September of last year on it. And I went about 300 miles to a neurologist. We did a physical exam, and then she ordered an EMG that was performed that same morning on it. That was in December. And in early March, I was out at Mayo trying to get in with their peripheral nerve clinic. And they had ordered another EMG even before I could get scheduled in with a doctor. And then I did end up on their cancellation list. It so happened they had a storm, and I got in within 2 days of when I got out to Mayo to see the specialist. So there are ways to get moved up on the list.
That's an excellent suggestion when you get an appointment 8 months from now to ask to be on the cancellation list because they're motivated to bring you in because they hate to have an unfilled appointment because of the loss of revenue. So they will call you if they have an opening, especially if you're like a lot of us guys here, retired, and you can come in at the drop of a hat. Thank you, David. Rick?
Yeah.
Yes. So I was just going to say to you, Richard, to bear in mind a couple of sort of easy things to do if you haven't done them yet. Acupuncture can work. Dr. John probably knows more about that. I can tell you more. I use B6, 100 milligrams a day, which I get from CVS. And believe it or not, it really It really works for me. So you might try taking B6, and I think you can take a fair amount of it, but check with your doc. Be sure to check with your doctors. But those are a couple of things without going to pharmaceutical drugs to handle it.
Mm-hmm.
Or going to CBD, which I keep on running into with every.
Well, yeah, I mean, it works for some people, but I try the B6 first.
Yeah. Well, I
Um,
tried it when you recommended it.
Didn't work.
Yeah, it did, but don't I? That was what, almost 2 years ago.
We'll get some more.
So many things happened. I dropped that. But I
Yeah, we'll
still have
go.
a bottle of it. I know.
Go down the drugstore, get some more, take a couple a day. Let your doctors know what you're doing. Take a couple a day and see if it makes a difference. And play around with the dose. But you know that B6 has really, really helped me. Mr. Valens, you have your hand up.
CBD massage into my lower calves helped me. So there's one plug for CBD.
Okay.
Okay. But I mean, if you look at the internet, oh, that is the best thing in the world. Oh, everything. I'm going, yeah, I'll believe it.
Oh, and look, Captain Jim says he takes 100 in the morning of B6 and 200 in the evening. It took a little while to kick in, but it's helping now. So go back to that as well.
That makes more sense. And I think it worked. Oh, by the way, Dr. John, your comments about a terp. I had
About the terp?
Yeah, I had the surgery.
Oh.
And other than taking a while to get over, and I've got one medication. What is it? I have to go look. Is Gemtesa? Gemtesa, yes, and that is working. I'm a happy camper. And
good.
For 4 years, the biopsy on the call it the cuttings came out with the same answer with the foamy gland cells. So,
yep.
So anyway, that part is halfway stable.
Oh, great! That's great to hear. I forgot to ask you about that.
Yeah, that's all
okay.
I got.
Let's go to Robert. We were going to have you catch us up a little bit.
Do you want me to start, Dr. John? Do you have any start with questions? You let me know how you'd like to handle this.
Well, I'm not sure. I'm looking to Rick for guidance about that because he didn't think we needed to start you as a new guy. But Rick, what do we do right now? Do we just say catch us up since the last time?
I'll step in real quick. I think exactly where he started last night is a good place to start.
Okay.
I'm sorry, David, what was that?
Exactly where you started last night, where you had your RP in 2008. Just go from there.
Okay. 2008, I had my radical in April.
And that's in response to a 3+4 biopsy, right?
That is correct, in January of 2008. And Ash Tawari did at Weill Cornell did the surgery. Been taking PSA tests pretty much every 3 months, slowly going up. In May of 15, I hit biochemical recurrence of 0.24, had radiation and brought it down to 0.02. From that point, it's just been increasing very slowly. And as of January January this year, my PSA was at 2.88. Had a PSMA scan, clean, and going back, I've had 5 PSMA scans and 4 Axiom scans, 2 MRIs, few bone scans, clean. My PSA several days ago, it's 3.36. My radiation oncologist is Richard Stock at Mount Sinai. Then William O., who was at Sinai, is now at Yale New Haven, and I have an appointment with him week after next. Radiation oncologist says, come back 3 months, we'll consider doing another PSMA scan. When I saw William O. when he was at Sinai, and that was probably November, he says, you're an anomaly. I've seen this before, but it's slow moving. Whatever is growing is slow moving. We can treat it to bring a number down, but it doesn't make sense to bring a number down when nothing is manifesting on these scans. So that's it in a nutshell.
Whatever is making that PSA is either too small to see on the scans, or is some type of cancer that just doesn't make PSA. But your MRI, you said, doesn't show anything either.
Correct.
So it's not like there's a big tumor out there that's not expressing PSA.
Correct. And the Axiomins too. That's why I had an Axiomin in, I had a PSMA in September of 2 years ago, then an Axiomin in December, just see if that shows anything. And it didn't.
Yeah, it was a good idea because you get around the issue of needing to express PSMA in order to see it.
Right.
Did you have an FDG scan or just Axiomin and PSMA?
I'm sorry, what was that?
Did you have an FDG scan or just Axiomin and PSMA?
The latter, Axiomin and PSMA.
Never had an FDG scan?
No. I don't even know what that is, but no, I didn't.
That's plain glucose, just to see if there's anything hypermetabolic.
Yeah.
It's a type of PET scan that doesn't rely on PSMA to see abnormally actively growing cells. It's more sensitive probably than the CT scans and bone scans. That's why Jack was wondering.
Bob, when was the last time that you did the PSMA? In November or in June of 24?
January of 25 was my last PSMA.
January 25. Okay. And when was the last time you did an Axiomin?
End of December 23.
Yeah, that's what we suggested to you back in 23 because I have it written down here.
Correct.
My feeling is when you talk with Dr. O, you might talk to him about repeating that Axiomin scan. If nothing showed up, because back in January of this year, your PSA was over 3, correct?
2.8. January just went to 3.36. Yeah.
Okay. I don't know, Jack. Dr. Jack, you're the expert on this. This sounds very familiar. I don't know what it is about Muslin. He seems to find these people that that have the same.
Well, with me, it's 22 years ago, and being clean for 15 years, and it shows up, and slowly over 5 years, Robert, they didn't find anything, and I had 2 or 3 Axiomins, 3 PSMAs, a bunch of FDGs. I had a choline, C11 choline, couldn't find anything, and then until finally they found a PSMA and an Axiomin lit up when my PSA went up, lit it right up to like 1 point something, 1.9, and then eventually they got a biopsy done because they were able to find something through my lung, and they did a endobronchial biopsy, and they found adenocarcinoma. So I've been treated for 2 years, but it's a real quandary. I'm dizzy listening to your situation because it sounds very, very hairy and very difficult, and I'm scratching my head wondering, God, another lost, bizarre situation where they can't find it, and it's rising.
Yeah.
Very frustrating.
Rick, my PSA when I did that Axiom was 2.030.
Okay, thanks.
Which should be high enough if you look at the data to show something.
Yeah. The answer is yes, but then you're not showing anything on PSMA even at the higher, and we're now significantly higher on the Axumin, so maybe it'll show up on the Axumin. Here's what I would say. One thing I would say, Dr. O is a great doc, and following him from Mount Sinai to Greenwich makes a lot of sense, and I would feel very comfortable letting him guide me in this situation. I'm going to ask Len what he thinks, because he's been guiding Len for how many years, Len?
Oh, I think it's 8 years now. Yeah, I think I agree with you, Rick. It's a good move to follow Dr. O wherever he goes, if it's still logistically possible for you. But there's another fella in our AnCan group who I won't mention because he's not here tonight, so maybe it's not fair. But he has had a consistently rising PSA to the point where, if I recall correctly, it's now around 19. And he's still coming up negative on every imaginable scan. He's had PSMA, FDG, Axumin, CT, MRI, you name it. And even with a PSA of 19, even be higher than that, still nothing. And all they're telling him is he's kind of going back and forth between Mount Sinai and MSK. Not a Dr. O patient, but in any case, these anomalies, as Dr. O referred to you, they do happen. And, like this fella, extremely frustrating. PSA of 19, that's amazing not to pick up anything.
I guess that's good.
I don't know.
All depends your age and whatnot, but it is disheartening. No doubt about it. Because I've had friends that have had much lower numbers, but the cancer was apparently more aggressive, where PSMA lights up and they're able to radiate it. Assuming this person with the 19 had a prostatectomy.
I think he did, yeah.
I have to look.
Well, a long time ago, like
Yeah,
2008.
I'll check. I'll check and
You know
see.
who it is, right, Rick?
Yeah, I was trying to think, and now then the penny drops, and I figured, oh yeah, I know who you're talking about, but I can't. But I'm having a senior moment as to the name, but it'll come to me any seconds.
I'll just text it to you here.
Yeah, thank you. But but I can see him in my mind's eye. I know who it is. I know exactly who you're talking about.
Any other comments
Yes,
for Robert?
thank you. That's it. Thank you.
Gary?
I just have a quick question. Robert, you're not on ADT at this time, correct?
I'm sorry, what's that?
You're not on ADT at this time?
I'm on nothing.
Hey, can I just throw out a general question to the group?
Yeah, of course.
About ADT at this point. I mean, is there any reason why not?
I don't think he's ever even been on ADT. Have you, Robert?
No.
Ever? Why is that? I know you were diagnosed, I don't know what it was, 18 years ago or something like that, but why were you never on hormone treatment? Maybe they thought the radical prostatectomy had cured you or something?
Yeah, because I was very on top of it when I was diagnosed, and I just went through a shock that I even had it, according to my urologist, and a shock that there was a recurrence because everything was clean. Everything was clean.
I mean, I just don't get why, when your PSA is going up, if, you're talking about PSAs at over 3 and PSAs of 19, I just don't understand why somebody hasn't at least started ADT to see if your PSA is going to go down.
Yeah,
other than doing all the damn tests.
Yeah, we didn't say, Gary, we didn't say the guy with the 19 hasn't been on ADT. Don't assume that. The guy with the 19 has been on all kinds of different treatments, and he actually did. We worked with him for a long time after he first got diagnosed back in 21 to get him to debulk the primary, and eventually he did debulk the primary with SBRT, but he didn't have surgery, Bob. But he's been on different drugs.
Okay.
For lengthy periods of time.
Yeah, I mean, it's a good point as far as Robert is concerned. We're used to seeing people who recur when they get to point 2, they go back on hormone therapy, and he's gotten all the way up to 3, and nobody has said, "Oh, you're still hormone sensitive. Let's screw the scans. Let's put you on hormone therapy."
I think it's a very reasonable conversation to have with Dr. O as to whether he thinks there's a percentage, even though we can't see anything, does he think some treatment might be prophylactic? And at the same time, you probably don't want to do the treatment, but if you do want to do the treatment, one great thing about Dr. O is that he will manipulate the treatment to fit you. So he may not put you on 2 drugs. He may put you on monotherapy darolutamide like David was on, or something like that. He might be willing to do that. But I think it's a discussion to open. David, what are you thinking?
Well, I just wanted to share, my story with Dr. Schmulowitz. My PSA is rising, but it's kind of leveled off at about 0.7, 0.75. And he looked me in the eyes and he says, "Well, do you want to treat the PSA number, or do you want to live, or do you want to live your, what do you want to do? You can either we can put you on ADT again, or just keep scanning and keep scanning every 3 months and see if we find something." And for me, I'd rather not go back on ADT and keep scanning. But my PSA number is not as high as Bob's. So it's a real personal choice whether you want to treat the PSA number or wait to find something to treat. And I think Bob, everybody's right. Dr. O is going to be a great resource, and excited to learn what he says to you. But it's a personal choice. And Bob also, by the way, is also pretty high strung, so to speak, and he gets nervous and he gets scared. And maybe for some people, it's worth it to just get that number down and live with the ADT for a short while. You may not have to be on ADT long, but I think Dr. O will guide you well.
Can I say something? All right.
Yes.
When they were searching for my origin of my cancer for 5 years, I remember Dr. Carroll out in California was discussing with me how they can manipulate either was the testosterone and or the PSA, and make the PSA go down, I think, and the testosterone go down by giving me ADT. as a way of making me more PSMA avid. And I distinctly remember there was some correlation between PSMA avidity and lowering of the PSA. And as the PSA was up, and the testosterone was up, that somehow it made the PSMA less avid. What is your testosterone, Robert?
I don't know. I can't remember what the last
You don't-
test was.
Well, do you have an idea what it's been?
It's been on the low side of normal.
Okay. Just wondering about, possibly that being an option for you to bring out some PSMA. Has anybody else heard of that? Or is that just my personal discussion with Dr. Carroll?
No, I've heard it as well, Doc.
What did you hear?
I heard that ADT can make you more PSA avid, that you're more likely to show up. I've read that.
Yeah, I think it upregulates the antigen, Dr. Jack, from what I remember reading. I just saw that recently somewhere too.
It was in Med. I think it was in MedPage, Rick, not too long ago. And I don't know where they got it from, but
yeah.
they did say that it made it more visible. Yeah.
This comes up when they test Pluvicto. You guys probably know they're testing Pluvicto out earlier and earlier in treatment, even before people have chemotherapy. And so the question of, well, do you do it sequentially or both at the same time? Well, if you do it both at the same time, your anti-androgen treatment will result in an increased expression of PSMA and therefore more vulnerability to a PSMA-directed therapy like Pluvicto.
Bob, come back and discuss what Dr. O said.
Okay.
Yeah.
Because we got a bunch of good heads in here, and it's going to be easier for us to help you translate what he said than for you to wrestle with it yourself.
Okay.
And that's really what we're here for. You can bounce off what he said to us, and we can take the good and the bad and play it around, and we can come back and see where you are. But I hear the pros and the cons, and but I do think that, yes, speaking to him about possible prophylactic treatment, even though we can't see anything, might be smart. But you really need an experienced guy, and that's what you've got.
He has a lot of experience, correct?
Yeah.
So next on my list is to go back and catch up with Larry Meadows, but I do not see him on my screen.
No, I see Larry, but I'm going to just intervene quickly because I just want to make sure.
Oh, there he is. I see him.
I just want to talk quickly to Stan Friedman and others about this TLX591 trial, which both
good.
Dr. John and I are very familiar with. Most of you are aware, I think by now, that the FDA recently approved Pluvicto to be used before chemo. So all of our ABC guys, who knows what ABC guys are? Come on, put your hands up. How many of you know what ABC guys are?
Already been chewed for gum.
Oh, come on. Nobody can tell me what an ABC guy is. And you've been here.
Anything but chemo.
Anything but chemo. Those are, and that's Chuck Ryan's. That's a Chuck Ryan term. ABC guys, anything but chemo. So all of you ABC guys who were trying to figure out how could you get to Pluvicto without doing chemo, and we found a couple of workarounds, and we had an idea that some of you could just maybe do one session. You don't have to worry about that anymore. Now, a few months before that FDA approval, maybe even as few as 2 months before, 3 months before, Telix launched a trial in this country. I think it's called Pros Global. What the hell is it called? Anyway, it doesn't matter.
Prostat.
They launched a trial in this country for a radionuclide before chemotherapy, and we put it in our reminder for several weeks. In fact, Gary V tried to get into the trial and was interviewed and tried to get into the trial, but he wasn't clearly eligible for a number of reasons. The big difference in this trial to Pluvicto, it has pros and it has cons. The pros are that it delivers the radionuclide therapy in 2 sessions. And it does that over 2 weeks. So you get an infusion at the beginning and an infusion 2 weeks later, and then in theory, you're done. Versus the Pluvicto, which is delivered up to 6 sessions, each 6 weeks apart, which is a huge difference. The problem that we see, the company doesn't really see it, but we are literally working with the chief medical director, and we're drilling down into this because we want them to be more conscious, is that the side effects may be more toxic over this shorter period of time, although the actual final dosage and period has not been tested yet. It's still in clinical trial, and we're still checking that out. So the trial's available in about 10 places around the country, including at Columbia University in New York City. And if anybody is thinking about Pluvicto before chemo, I would encourage them to compare TLX 591, and I put the reference high up in the chat window. I definitely encourage them to compare it to Pluvicto. John, do you? I'll tell you what's the name of this damn trial? I'm trying to Prostat. I should have remembered that. But the name of the trial is Prostat, and it's available. And by the way, if anybody's interested and needs to travel for it, Telix will pay travel and accommodation whilst you're getting it. Now, just want to say, Telix is a sponsor. All we're doing is publicizing the trial and making you aware of that it's available, because in my mind, it is a really good alternative, but it may be more toxic in the form that we see it right now. Dr. John, over to you.
Yeah, I quite agree. We're not recommending it yet. I'm actually right now setting up a meeting with Dr. Ahmed to talk about our toxicity concerns, but it's available and they're recruiting.
Is it only for hormone resistant patients?
Don't know.
Yes, it is only, yes, because that's the issue that Gary V had. It's only for established hormone resistant. And so for people who have been on drug holidays and what have you, it can get a little, it's almost a call by the doctor and by Telix. If you're not clearly resistant, you might have gone off and then you've come back, taken a holiday and come back on, and now you're going up a little bit again now. It's loosey-goosey around what the definition of hormone resistance, of castrate resistance is.
But you're supposed to be recurring on current treatment. So I think if you're on a holiday, that might kick you out, right?
I also want to say that same issue is true with Pluvicto. It's not really clear if you look at the Pluvicto what castrate resistance actually means, because it's also supposed to be for castrate resistance. It hasn't been approved yet. Neither of them have been approved yet for people that are officially hormone sensitive, as far as I know. But it's a great point to bring up, Dr. Jack. Thank you.
Okay, shall we go to Larry?
Yeah, unless anybody has any questions. Anybody?
Steve has a question.
Go ahead, Steve.
With this different treatment other than Pluvicto, is it any less impactful on the salivary glands?
Yes. So it's still with lutetium. They're still using a beta radionuclide. It's not an alpha radionuclide, but they're using a large molecule antibody, molecular antibody. What's the official term of that? The ligand that they're using?
I forgot its name.
Okay, but and the reason it works the way it does is because it's a much larger molecule and it stays in your system for a longer period of time, so it's able to deliver more in each dose than the beta. And because it's a larger molecule, it doesn't get into the salivary glands in the same way. This is a molecule that was originally developed by Dr. Tagawa at Weill Cornell, and we know some people who have used this molecule in trial. But yes, it has, in some aspects, it has a better profile than Pluvicto, and in other aspects, it has a worse profile than Pluvicto.
It's called Rosopatamab tetrazetan.
Right. And what's the generic name for that type of ligand?
The linker?
Yeah, the linker.
Is that the same one as J9? What is it, J9?
It's the same linker as J591, which is
monoclonal antibody, right?
Oh yeah, NAB, the monoclonal antibody.
That's what I was trying to remember. See, if I keep talking around it, it comes back to me. I dig it out of there. It's a monoclonal antibody. Did you want to say something about it, Len?
Oh.
Oh, I just got it. Oh, I got it with a mouthful. Bingo! Yes. Okay. All right. Len will come back and tell us if there's anything he feels that we should know about it. But I do want at least our AnCanners who attend and who watch to be well aware of this TLX591. And you can write to me and I can provide you with more information. And I also put the link in the only thing with that link in the chat window that goes to clinicaltrials.gov is that the locations are not up to date. So there's a couple more places that it's available which don't show up. Like, for example, it's available at Columbia. We have that on the map that they gave us. But it isn't on the website on clinicaltrials.gov. Dr. John, you're excused. No ifs, ands, or buts. I'll handle Larry Meadows.
And then after Larry, Dan has a question.
And after Larry, Dan has a question, and then I'll take any more. I got Larry, I got Dan, and thank you so much for helping us out with the vets.
Okay, good night, gentlemen.
stay as long as you like. You can go over whenever you like. And any other vets who are on here, you can jump over to the Schmier room and have some fun there. Okay. Let me pull up my notes on you, Larry, because I did find them just before, so I know I got notes on you. And once I got those notes open, I'm going to ask you to bring us up to date, because my notes may not be accurate and I can correct them. The last time I remember talking to you was in February of 22. That's 3 years ago.
I think you're right.
Okay, well, why don't you give us a quick summary of your situation, and let's see how we can help you.
Yes, sir. Okay. Not much help needed, but I just want to bring you up to date. Throughout my adult years, I was very good to have annual physicals, and all was well until late 2008, when my PSA went from below 4 to 5.6. And so that led to biopsies, and 3 + 4, 7, and I had a radical prostatectomy. And with clear margins, they said. However, I had it also showing up in my seminal vesicle. So as time went on, then throughout the next 12 years, I had 3 calendar sessions of radiation therapy. I've had 5 PET scans, and 2 of them were choline. One was Acumen, and I had the last one was at an acetate scan too. But the last one that I had was in November 2021. That was a PSMA scan, and all these showed nothing. So anyway, being a resident of North Phoenix, Rick gave me good advice. I was kind of leaning toward going to Mayo, and he gave me 2 names that I might want to check into, Dr. Bryce and Dr. Moore. And at the time, Dr. Bryce was seeing no new patients. So I was able, fortunately, due to Rick, that I got in to see Dr. Moore. And I gave all my history to Mayo, and they did some scanning on me too. But then as of April in 2022 is when I started my Lupron quarterly shots, and Erlita, apalutamide, 4 pills a day. So that went on for 2 years. And right now it's April, and I am just at my anniversary of my first year of no medicines, drug holiday. So anyway, I just want to give a shout out to Rick for giving me the direction of seeing Dr. Moore. Because as time went on, I was browsing through Mayo information one day, and I discovered that she is a researcher for Mayo at prostate cancer. And just to throw in, by the way, Mayo North Phoenix has recently completed construction on a new research building, so she's part of that too. So I feel very fortunate that I'm in a situation that I am, and all during this time, my testosterone got down to, I think it was 8, and normal for me is about 560, and my PSA has been undetectable and remains undetectable throughout this last drug holiday year. So I'm very thankful. So here we are.
Well, that's not. I'm very happy for you. You should know, should you ever need it, that Dr. Bryce went to City of Hope in Phoenix.
Mm-hmm.
And he is probably our preferred GU medical oncologist in Phoenix right now. I certainly would he'd be my first choice. Dr. Moore would probably be our second choice. But this treatment path sounds great, Larry. And what's your testosterone back up to?
The last blood draw that they did, it was up to 112.
Okay. Well, what I would say is, if they ever need to put you on a hormone therapy again, make sure they use Orgovyx and not one of the other drugs. The reason being that you will come back much more quickly.
Okay, thank you.
And it's a pill form. Orgovyx is a pill, so it's not a shot. And that's what. Is there, number one, is there anything we can help you with other than just a report? And number two, does anybody have any questions for Larry?
I have a question. Larry, I didn't
Hold
hear.
Hold on a minute. Hold on a minute. Stick your hand up, Dr. Jack. Do you have any questions for us?
I do not have any questions for you. I do have a couple comments, but
yes.
Let me hear Dr. Jack.
Okay, Dr. Jack.
I missed something in the beginning. Did you say you had everything was confined to the pelvic bed when you started treatment, or did you have anything out on the periphery?
It was in the seminal vesicle.
Just the seminal vesicle.
That was discovered at surgery. Right. They discovered that.
So they just cleared everything surgically, and then you had no radiation after, no adjunctive radiation?
No, it was about 20 months later, I had my first session, 42 sessions of radiation therapy. And then 2 years after that, when they did an acetate scan, C11 acetate, they discovered a lymph node that looked a little questionable. So that resulted in about 5 months. And then Mayo did chest CT, and the radiologist discovered that there was a little suspicious looking lymph node, and so they did a biopsy of that, and sure enough, it was positive for prostate cancer. So I had 5 days of radiation, and that's the last of it.
So we have that in common.
Yeah. Oh, another thing we have in common, I had surgery on my hand because I have carpal tunnel problems, and I had some steroid injections on my left hand and the surgery on the right hand to cut a ligament, and so far we're doing well. So I know you have that problem too.
Thank you for remembering.
Another thing I'd like to throw out is in last Monday, the 14th, in that session, at minute 70, you started talking to a gentleman. I think he was Dan.
Yes.
And
hold on. Time out. Michelle, it's in the Schmier room, my dear.
Oh, okay, the Schmier room. I'm sorry.
That's okay. Listen, I just want to say I am so happy that you knew about it, because I wanted to make sure you did, and we don't have your email anymore. But I called Alexa, and Alexa said you did know. So go over to the Schmier room. They're all there. Okay?
All right, sir. Thank you.
Bye.
Bye.
Sorry, sorry, Larry. That's one of our lady vets, and so I'm so pleased that she's going to the meeting.
Yeah, that's okay. An important feature about a nuclear medicine bone scan is that the radioactivity clears out through the urinary system. And so if a person has a potential problem in the pelvic area, it's probably they're going to get a good readout from the old school nuclear med bone scan, because it's liable, the hot spot that might be there might be overshadowed by urine being in the bladder. And there's no way that you can make a bladder so empty that it's dry. And so that there's always that possibility that you're going to miss it if you got a problem in the bladder. And one other comment that I had, I think this gentleman said that it was the rheumatologist who said that it would be very, very difficult to do a needle biopsy there. But am I mistaken? Do rheumatologists actually do needle biopsies? That sounds like more of a specialty that a radiologist would do. And if that's true, then he should seek information from he who does it most and best, a radiology specialist. Okay, that's all.
Yeah. No, listen, it's good points. I'm trying to think who the heck it was last week who had that spot where they were telling him they couldn't biopsy it. But
that was me.
I think
that was me.
Oh yeah,
it was you, Dan. Well, you're up next, so we'll talk to you about it. But yeah, I mean, it's probably better to hear it from an interventional radiologist. But these doctors have experience, and they pretty much know when they have a patient who they've ordered for a biopsy, whether it's going to be successful or not. So you have to rely on them to some extent.
Mm-hmm.
That's the reason why. But I'm glad you raised it, and I'm glad Dan's still here. So Dan, is there anything else, Larry, or can we segue over to Dan right now?
Yeah, segue over. I'm finished. Thank you very much for your time.
Okay, and great results. Great results.
Thank you.
Dan,
thank you so much.
There you go. You got you were heralded.
Great segue. Thank you, Larry. Since that time, my oncologist, even though she's out of town now for 2 weeks, she's agreed that the biopsy is necessary, or we'll talk about it when she gets back, not the nuclear medicine scan that you were talking about.
Okay.
And I agree that whoever would do that biopsy or in any treatment afterwards, radiology, you really need to talk to the specialist, but we haven't come to that point yet. We're still or at least they're still evaluating it. So putting that all aside, my simple question, has anybody done any investigation of whether prostate cancer can lead to testicular cancer?
Ooh. I wouldn't say I've done investigation, but I don't think so. I've never heard of it. I can ask Miss Alexa because she's very knowledgeable on testicular cancer. Her partner has metastatic testicular cancer. But I have not heard of testicular and or metastasis. I've heard of metastasis on one instance to the penis, but not to the testicles. How about you, Len? Have you ever heard of any connection?
No. I mean, if there was a connection, it would probably be more due to radiation, secondary cancer from radiation, rather than have anything to do with the prostate cancer itself. And we did have somebody who had, it was Les Shelderup in Minnesota.
Yes.
Right? He had a prostate metastasis to one of his testicles. And they were all shocked because it was very rare.
That's right.
Yeah, it wasn't testicular cancer. It was prostate cancer.
It was prostate cancer. And then we had another guy who had, in Phoenix, Doug Matthews, I think his name was. I don't think he's with us anymore. Who also had some issue, but I think it's with his penis and not with his testicles. But why do you ask, Don? Why do you ask, Dan?
Because my oncologist will be out of pocket now for another week, and I'm beginning to evaluate maybe it is a combination of arthritis, obviously, because I've been diagnosed with that, but also something else. Even though my PSA is undetectable, there's something else going on.
It's
Being
real hard.
specific.
You know, when you have weird stuff going, I hate to say this, but you've heard me say it before. When you have weird stuff going on, Kaiser's the worst place to be.
Yes.
Because they don't go the extra mile, and they don't have those resources for those sort of people, and they don't want to send you out because they won't spend the money. So what it means is you got to get your ass out of, at some point, you got to find a way to get your ass out of Kaiser so you can get to some real quality care. I know you don't want to hear that, but I don't, you know, I don't know. At the same time, it really shouldn't be for you to figure out what's going on. And yes, there may be something else going on, but I would doubt very, very much whether it's testicular. Has your cancer ever been sequenced by? Have you ever had any somatic sequencing done?
She did send that back, and yes, it came back negative.
Not genetic sequencing. Not
No,
genetic.
somatic. And it was negative for any mutations.
And it was negative for any mutations. And that was pretty recently then. It must have been within the last 12 months.
Within the last 12 months, yes. Within the last 9 months, probably.
Okay. I don't know. I just don't know. I mean, in a situation like this, we would be sending you to Dr. O or Dr. Elaney or somebody like that, you know, who's Dr. Schmulowitz, somebody who we know is going to dig around and look around and try and get to the bottom of what's going on. It's really hard at Kaiser. You know, we can't even get them to do up-to-date treatment.
Right. My PCP is very accessible, but when I brought up a referral outside, he said, well, that's Dr. Ferrara, who's the oncologist that would have to approve that. And even though Jim Marshall was able to get around it, it was only because he was in the veteran system.
Well, that's right. He didn't. Jim Marshall got around it not through any help from Kaiser. He got around it because he was a vet.
Right.
It's really difficult to get an outside referral to a GU medical oncologist at Kaiser. They don't believe in them.
Right.
And they haven't done as long as I've been around them.
Although I don't want to speak out of turn here, but Jim Marshall just sent me an email on Monday because we were going back and forth about this. When he was talking with Dr. Paller, she indicated that Kaiser hired somebody to head the whole GU system. It won't be immediate overnight.
Yeah, I mean, yeah, they've done it in other places. We know they've done it in Northern California. We know a couple of people there are being great. They need to do it, and then they ain't doing it. So what can I say? You know, but it's not going to help you in short order. You know, the worst that you can do, although I doubt you'd ever want to do it, is if you moved, you would be able to reset and you could choose a traditional plan. But that's, and then you're open. Can't hear you. All of a sudden we lost you. I don't know why, what you just did. But we lost you. There you go.
That was the trajectory I was on 6 months ago. It's a whole different situation now, but I might investigate that again. Thanks, Ray.
Yeah, I mean, you know, if they stop the program, which is what happened to me, and I was able to switch, I switched from Advantage to traditional Medicare. But other reasons you can switch is if you move.
Right. Exactly.
So, you know, and if you move, then all bets are off. All right. Well, but I wouldn't say that testicular is likely. but could it be from a different type of cancer? Maybe. I wouldn't even want to speculate, Dan.
Right.
I just don't know.
Thanks.
Any other comments from anyone? And is there anyone who would like to ask a question, Phil or John? John M., how did you do with your brachy today?
Well, successful. I had brachytherapy. I got there at 5:30 a.m. at Loyola in Chicago, and Harkenrider did my brachytherapy, and everything went well. I came home and I ate a good meal because I'd been starving. So the real test is, and by the way, did I urinate? Yes. After the procedure, yes. But we really won't know how this all turns out for a few weeks. But incredibly long day. It's a brachytherapy boost. It's temporary seeds. And so I left with no radiation in me. I feel good. It's a major part of my treatment that I've just moved through. So I feel good about it. That's it. I just wanted to share with the group.
Are you sore or not?
A little bit. When they put 17 needles into me, 17.
Yep.
And after they disconnected me to the machine, I kid you not, they pulled out all 17 with one large jerk. And that hurt a lot, but I'm convinced they knew what they were doing. It was the right way to do it because, 2 minutes later it felt better. But man, that was wow. I jumped out of my seat. So I'm sore. I'm sore, but it's good, right?
So let me ask you, was it one large jerk who pulled out those needles?
The person that did it was actually not the person who put them in. Let's put it that way, right? So it was one of the support team, and it was one large pull, and it was good. I give kudos to his support staff that did a great job of supporting me all day long.
Okay.
So just wanted to give that to the group. I don't have any big questions, so that'll probably come later. Thank you.
And this is one application. He's not doing 2 applications, correct?
No, it's one. It's a brachytherapy boost. I got 15 gray.
Okay. Well, the reason I say that is because they're always a brachytherapy boost, but sometimes they can deliver HDR in 2 sessions, and sometimes they deliver it in 1 session. So they're giving it to you in 1 session.
1 session right now. So
right.
That's it.
Okay.
Looks like we have some questions, right?
We do have some questions. We'll go to John Graff first.
So no catheter? That you didn't go home with the catheter? They sent me home with a catheter. That was the bad part.
No, they took the catheter out, and that was actually every bit as bad as the needles.
Yeah, I had to take it out myself. It was not fun at all. Anyway, congratulations on. Are they going to do the radiation now, or have you already done the IMRT?
The radiation is going to come. He said anywhere from the next 2 to 3 or 4 weeks, we'll start the 25 sessions, 5 days a week.
So you and I are on kind of similar path. I just finished my brachytherapy about 2 weeks ago. I'm about to start radiation now.
Okay, good. You and I should talk. I sent you my email address in the chat. Get a hold of me, and then we'll talk offline, okay?
All right, sounds good, yeah.
Very good.
Sounds good, yep.
Excellent. I love it. I love it when we have brothers who are just about at the same spot and can support each other. That is the best.
Us brachytherapy guys got to hang together, right?
What was your Gleason score? Just wondering.
My what score?
Gleason score?
I was 3 cores of Gleason 8, 4-4.
So yeah, very similar.
Yeah.
All right. That's really good. Dr. Jack, you have a question.
Just only if we're finished. I have a question that's unrelated to what we're talking about, but related to something I think is important because we've been talking about it.
Okay. Are we finished? Does anybody else want to say anything to Mr. Maxwell?
Thank you, all of you. This is an amazing place to be. And John Graff, you should come back every 2 weeks, and maybe more often than that.
Every week. You can come back every week if you like. You know, I wonder when they pulled those 17 needles out, whether John thought the silver hammer had come down.
Oh my God! I can't even. You're making me think of it again. It was painful, but it was brief. Pulling them out one at a time would have been worse. I'm convinced of it now.
Right? Okay. Yes, the floor is yours, Jack.
Just a quick question, because you posted something I signed up for, and it's 4:00 this Thursday, and it's in line with what we were talking about the PSMA biology. Amisha Beltran is going to give a lecture, a webinar, and
yes.
I'm going because, and I asked a specific question which has to do with, how can we measure and determine what the PSMA is for avidity prior to doing a PSMA scan? And I was wondering, all along that's been a question we've pondered, and it's something we briefly alluded to tonight with testosterone and whatever. I wonder if maybe she's going to be able to answer that question. I saw somebody at Sloan Kettering who does research and said something to do. You're able to do it with an antigen and an antibody in vitro, and they're able to take a piece of tissue from your cancer, and they're able to find the antigen and the antibody for the PSMA. I don't know if that's what they're going to tell me, but it's certainly something I'm curious to know.
So isn't this, aren't you talking about the Australian?
Yeah.
Yeah.
4:00 Thursday.
Well, I will say that it's usually very understandable, but pretty highbrow. They're usually very, very good, as Len will verify, so you won't be disappointed. Dr. Misha's terrific.
Yeah.
She's absolutely terrific.
Yeah.
And she knows us at AnCan. So there's a good chance you might get an answer to your question.
Okay, I hope so. Should be interesting anyway.
Okay.
All right.
Rick, I have a quick question for you, since you probably
Yes.
know more about HDR.
Yeah.
17 needles, isn't that an awful lot for HDR? I always thought it was like less than 5.
Yeah, I must say I did too. It sounds like a lot, but they have this big grid, and I guess it all depends where the location of the cancer is. I mean, I don't know, but yes, it sounds like a lot to me, but what do I know? So
maybe John Graff knows.
How many grays did I forgot to write it down? How many grays did he say he had?
15, he said.
15?
Yeah.
I better write that down. I think, or maybe I did write it down. Did I write it down or not? No, I didn't. How many grays did you get, John Graff?
I had 15 grays, yeah, and they did 16. It was something out of Hellraiser, It was very, very strange. They put a battleship grid in your perineum.
Yeah, yeah.
And they put the needles in. It's definitely an experience.
Yeah, yeah.
I think 16, 17 is normal.
Maybe that's how they do it now. I mean, back in the day when I got my Brachy, I got permanent seeds, and I thought they were using fewer needles back then, but it seems like it's changed, moved around. Okay, there you go. Look at this. John Graff, this is a special day. Len Sierra stayed with us all the way through to the very end. Oh my God! I didn't
want, with John gone, I didn't want to abandon you, Rick.
You're it's very, very. John, did you have a question, John Graff?
No, I'm good. Thank you very much.
Oh, okay.
Appreciate it.
Okay. All right. So,
Rick, I had just a quick question. Somebody named Phil has joined us. Is he looking for the veterans group?
No. Phil Yorston comes in and out But we haven't seen him for a while, but he doesn't have anything to say to us because otherwise he would have spoken up. But I
Okay.
saw him come in, and he lives somewhere close to John Graff, actually. Where do you live, Phil?
Near Don Rogers.
Oh, okay,
But
you're
south
further
of whoever's
south.
in Melbourne. The other person from Melbourne went to Tampa. I'm half an hour south of Melbourne. I went to Miami.
Yeah, but I thought you were relatively close to Melbourne. You are half an
Yeah,
hour
half an
south.
hour.
That's
Half an hour.
close enough by AnCan standards.
And when
It's
I go for
close enough
treatment,
that
I
you
only
could
go.
get together for a cup of coffee.
Yeah, I don't have to go so far. I only go to Deerfield for treatment, which
Okay.
is an hour north.
Okay. Thank you for watching out,
Okay,
Harry
thank you.
Peters. Okay. Good night, everybody. I'm closing up.
Good night.
Good night.
Good night.